Okay, so hey everyone, welcome to our weekly seminar. So today's seminar is going to start off our oncology series by having a look into the topic of oncological emergencies in surgery, whilst we also touch upon key concepts like communication and breaking bad news, as well as consent and capacity. So, first of all, what is an oncological emergency? So, an oncological emergency is any complication related to cancer or anti-cancer therapy that requires immediate intervention. And some complications take weeks and months to develop, whilst others manifest in a few hours and lead to severe outcomes like paralysis and death. So, there are two different types of emergencies. There are single system emergencies and systemic emergencies. Single system emergencies, they're acute and organ specific, where the problem is confined to one anatomical system. So, deterioration is usually driven by local pathology. And usually, in this case, a surgeon prioritizes stabilizing and decompressing a specific area so that no other irreversible damage occurs. Whereas systemic emergencies, they involve a whole body physiological collapse, which is triggered by cancer or its treatment. And this affects multiple organ systems simultaneously and therefore requires a more broader medical stabilization. So I'm going to go on to talk about a couple of examples. And when I talk about management, in this case, I mean the initial steps taken before a treatment is decided upon. So first of all, we're going to start off with hemorrhage or bleeding. So there are three types. There's disseminated intravascular coagulation, and this is an abnormal bleeding and clotting cascade, which is due to an inappropriate thrombin activation. Then we have hemoptysis, which is basically coughing up blood from the lower respiratory tract. And then GL bleeding, that is blood loss anywhere along the gastrointestinal tract. So, some of the causes can be due to underlying malignancy, non-malignancy related factors, or even antineoplastic therapy. And this is a therapy where you're using medication to treat cancer by stopping the growth of malignant cells. So then, in terms of the basic investigations you would do once you find out that a patient's bleeding, is that you would do a complete blood count. So you look at the hemoglobin, white cells, platelets, and you would also do a blood smear where you're looking for abnormal white cells and platelets, and also looking at fragmented red cells as well. Uh, Prothrombin time measures the extrinsic pathway of coagulation, whereas the activated partial thromboplastin time, that looks more at measuring the intrinsic pathway of coagulation. And then you have D-dimer and fibrinogen level, and that basically assesses the clot breakdown and clotting factor availability. So, in terms of management, you could you would use a transfuse packed red blood cells, or if you want to correct any coagulopathy, you would do so using fresh frozen plasma and platelets as well. And these are some of the initial management steps you would take when a patient's suffering from hemorrhage. Okay, next we're going to go through brain metastasis. And what this is that you have cancer cells and they break away from a primary tumor elsewhere in the body and then they spread to the brain. So, in terms of presentation, some patients may experience subacute onset of a headache, and this occurs in 50% of cases. There's also impaired cognition, seizures, and hemiparesis. And what hemiparesis is that it's partial weakness or the loss of movement on one side of the body. So increased intracranial pressure and seizures lasting longer than 30 minutes, that's when it's considered an oncological emergency. Um, in terms of diagnosis, you could use either a contrast enhanced MRI or a CT scan can be used as well, but the only difference is that a CT scan is less sensitive. And then in terms of management, you would treat elevated intracranial pressure with something known as dexamethasone, Or you can even use anticonvulsant therapy with a short pacing benzodiazepine that can be used to halt seizure activity. And it's also important to note that when dealing with oncological emergencies, this also highlights the importance of an interdisciplinary team as well. As for example, in this case, you're dealing with a condition to do with the brain. So therefore, in this case, you would consider consulting with someone in the neurosurgery department to get a surgical opinion for them with them as well. So then we have superior vena cava obstruction. So what is superior vena cava obstruction? Well, this results from partial or complete obstruction of blood flow from the superior vena cava to the right atrium. This obstruction may be caused by vessel compression, invasion, thrombosis, or fibrosis. So in terms of presentation, patients may experience facial, neck, or arm swelling, dilated chest vessels, dyspnea, which is uncomfortable breathing, and orthopnea, which is shortness of breath when lying flat. And they can also experience headache or confusion. So the sudden onset causes rapid elevation of pressure in the superior vena cava. So this can cause increased intracranial pressure and cerebral edema. It can also cause intracranial thrombosis and bleeding and may also lead to death. So what cerebral edema is, that's basically the accumulation of fluid in the brain. So in terms of diagnosis, you would mainly use a contrast enhanced CT scan of the chest wall, and this helps you clearly identify the level and extent of the blockage. Then, if a patient, sometimes they can't tolerate the contrast medium, so in this case, you would use an MRI scan instead. And then, in terms of venography, so what that is, first of all, that's a minimally invasive X-ray procedure where you're injecting contrast dye to be able to visualize blood flow and map out your veins as well. So you would mainly use this if you, for example, planned ahead to do a surgery, and that's when you would use this technique. And then if a patient has no prior diagnosis of malignancy, that's when you would want to use biopsies and histologic diagnosis as well. So, in terms of management, you would first of all, the most important thing would be to secure the airway and administer corticosteroids. And management here is mainly guided by the severity of the symptoms and the underlying malignancy, as well as by the anticipated response of the treatment as well. Next, we have spinal cord compression. So the most common site of spinal cord compression is the thoracic spine. And as you can see from the image on the slide, what spinal cord compression is, you have a tumor in a specific area, and that tumor squeezes the spinal cord, and that's what spinal cord compression is. So in terms of the presentation of it, some patients may experience back or neck pain associated with leg weakness. They can have a loss of bowel or bladder control and reduced perianal sensation. So in terms of diagnosis, you would most likely use a full MRI spine, but you can also utilize things like a CT scan, plain radiography, or a myelography as well. And in terms of management, you would again, in this case, use corticosteroids. And there's also this thing known as the spinal service, which can also be consulted for a surgical opinion as well. So those were all examples of they were examples of single system emergencies. So now we're going to move on to systemic emergencies. So first of all, we have febrile neutropenia. And what this is that it's a fever that a patient gets, except this patient also has an abnormally low count of neutrophils. And neutrophils, they're basically infection-fighting white blood cells. So it's the most common complication related to systemic cancer therapy, and it's also potentially life-threatening. So it also causes spontaneous bacterial infection as well. So the presentation of it, you would expect patients to have a fever higher than 38.3 degrees, for example, or a patient having a temperature higher than 38.0 degrees for more than an hour. In terms of diagnosis, you would want to investigate for the source of infection through history or a physical examination. You would also use pan culture to identify the pathogen. So pan culture means doing things like blood cultures, urine cultures. If they have respiratory symptoms, you would do nasopharyngeal swabs or chest x-rays. And you would also assess for signs of sepsis and initiate aggressive fluid resuscitation as required. And in terms of the initial management of this, you would want to use antibiotic therapy. And there's also a guideline known as the Cancer Care Alberta Febrile Neutropenia Guideline as well that doctors can follow. Next, we have the hyperviscosity syndrome. So what is hyperviscosity syndrome? Well, that refers to the symptoms from increases in blood viscosity. And causes of this can be due to increased protein content, large molecular size, and abnormal shape of immunoglobulin molecules. So in terms of the presentation of this, patients can experience neurological manifestations like headaches, dizziness, vertigo. They can also experience a triad of bleeding, visual disturbances, and hyponatremia and hyperkalemia may also be present. So to explain some of this, the triad of bleeding are elements that severely impact the body's ability to stop bleeding. So these elements are hypothermia, acidosis, and coagulopathy. And hyponatremia, that basically means you have an abnormally low concentration of sodium, whereas hyperkalemia means you have an abnormally high level of calcium. So in terms of diagnosis, you'll base it off the clinical symptoms and also look into the serum viscosity levels. So anything from like 4 to 5 centipodes, that's usually when symptoms begin to occur. You would also suspect a patient to have this condition if they have marked elevation of total protein. And you would also look into an electrolyte panel, peripheral blood smears, measurements of quantitative levels, and imaging studies. And to look, if you want to look into patient if you want to manage this condition in the short term, you would want to reduce blood viscosity, and you would accomplish this through plasmapheresis. So what is plasmapheresis? Well, that's a procedure that filters blood to remove harmful antibodies, toxins, and abnormal proteins from the plasma. So next we have syndrome of inappropriate antidiuretic hormone secretion. And this results from an inappropriate production and secretion of ADH that can lead to water retention, hyponatremia, and hypoosmolality. So the presentation of this is that patients may feel weak or fatigued. They may have an altered mental state and delirium, vomiting, anorexia, and also muscle cramps. And in terms of diagnosis, this would be diagnosed after other conditions are ruled out. So, for example, you would want to rule out things like renal failure, adrenal insufficiency, hypovolemia or hypervolemia. They all need to be ruled out first. And then that's when you would decide that, okay, this patient is most likely experiencing this condition. So what I mean by the terms hypo and hypo basically means you're abnormally low in something, and hyper means you're abnormally high in something. So for example, hypovolemia, that means you're abnormally low in circulating blood volume. And you'd also look into the serum sodium, serum osmolality, the serum levels of certain elements. So in terms of the management, you would look into treating it guided by the symptoms and also the severity and duration of hyponatremia. And if it's an acute condition, you would mainly focus on restricting fluids, whereas if it's a chronic condition, you would want to restrict fluids, but also look into using pharmacological therapies as well. So then the final condition I'm going to be looking at is tumor lysis syndrome. So what is tumor lysis syndrome? Well, that's the cellular breakdown in rapidly proliferating bulky or highly chemo radiosensitive tumors. And it also means the subsequent release of intracellular contents into the bloodstream. So In terms of the clinical manifestations, patients may experience nausea, vomiting, decreased urine output, renal failure, seizures, and sudden death as well. In terms of diagnosis, you would look into the clinical manifestations, but also look at the laboratory TLS as well, where you're looking into things like serum, uric acid, potassium, and phosphorus. So, in terms of laboratory TLS, you're looking at two or more metabolic abnormalities that arise within 7 days after the initiation of chemotherapy. So in terms of the management, you would use aggressive hydration with normal saline, rasburicase infusion. And what that is that helps rapidly lower the dangerously high levels of uric acid in the blood. And if the condition is severe or worsening, you may also want to warrant hemodialysis. So that would require an urgent transfer of the patient to a dialysis center as well. So now I'm going to pass over to Precious and Silver, who will be going through the next couple of slides. Let me know when you want me to move on to the next slide.
Okay. Thank you, Niall. Hi, my name is Precious, and I'm going to be going through the treatments that can be used for oncological emergencies. First off, we're going to start with the use of steroids. Steroids are normally used for acute metastatic spinal cord compression, or otherwise known as MSCC. It normally reduces the swelling around the spinal cord before definitive treatment. Now, the way it works is because normally cancer pressing on the spinal cord causes inflammation and edema, which is swelling. The high dose of dexamethasone, which is a steroid, reduces this swelling and relieves pressure on the spinal cord, helping to preserve nerve function. It is usually started like the administration of steroids is normally started immediately when MSCC is suspected, even before scans are completed. And then the advantages of using steroids is it works within hours, so it works quickly, it can reduce pain quickly, it helps to prevent permanent paralysis, and buys time until surgery or radiotherapy is done on the patient. And the disadvantages of steroids is it does not remove the tumor, and it can also cause long term, like because if you use it on the long term, it can cause side effects, which is the norm for all medical treatments, such as increased infection risk, high blood sugar, muscle weakness, stomach ulcers, and mood changes. Moving on to pain management. Pain management is normally used for severe back pain, bone pain from spinal metastasis, nerve pain caused by spinal cord compression. The way it works is doctors use a combination of medications depending on the severity of the pain. So I'm going to go through like a scale of pain. So starting from mild pain to like severe nerve pain. For mild pain, they'd give paracetamol, and then for a little bit of a bit wilder pain, they would give non-steroidal anti-inflammatory drugs. For example, ibuprofen. This would reduce inflammation, but these would normally be used cautiously. They'd also give opioids, for example, morphine, for severe cancer pain. And then for nerve pain, which is extremely painful, they'd give neuropathic pain drugs, for example, gabapentin. The goal using for the goal using these medications is to improve comfort and mobility while definitive treatment is being arranged, so the patient doesn't feel in discomfort the entire time they're waiting. Advantages of pain management are rapid symptom relief. It also improves the quality of life of the patient and allows the patient to tolerate further treatment and not make them feel as irritated because of the pain they'd be going through otherwise. Disadvantages include it does not treat the cancer, and opioids may cause drowsiness, constipation, and nausea. And the non-steroidal anti-inflammatory drugs may worsen kidney function or cause stomach bleeding. Um, Moving on to urgent early radiotherapy for acute SCCS. Is normally used for patients with spinal cord compression who do not need surgery and patients whose tumors are highly sensitive to radiation. How it works is external beam radiotherapy directs high energy X rays at the spinal tumor, damaging the DNA of cancer cells so they stop growing and gradually shrink. As the tumor becomes smaller, pressure on the spinal cord naturally decreases. So treatment usually begins within 24 hours of after diagnosis if surgery is not indicated or administered. Advantages of urgent early radiotherapy are it's non-invasive and is effective at relieving pain. It helps to preserve the mobility of the patient. It controls local tumor growth and prevent it from spreading to localized organs. And then the disadvantages of this is the tumor shrinkage takes days to weeks, so it's not as quick. And is less effective if paralysis has already been present for a long time, and side effects could include fatigue and skin irritation as well. Radiotherapy for untreated metastatic lesions. So this would be for other metastatic bone lesions that have not yet caused symptoms that are visible and could and preventing future spinal cord compression and also preventing fractures caused by bone metastasis. So how this would work is radiotherapy would be delivered to metastatic deposits before they become emergencies, and this would destroy cancer cells and strengthens the affected area by slowing tumor progression. The advantages would be to prevent future complications, fractures, and relieves bone pain. So the patient has to undergo subsequent surgeries and delays and progression of metastatic disease. Another disadvantage would be it would require multiple hospital visits in some cases and may cause temporary fatigue and cannot completely eliminate all metastatic disease. Moving on to post-separation surgery radiotherapy. This would be used for severe spinal cord compression, as we know, um, patients with spinal instability and tumors that don't respond well to radiotherapy alone. So this approach would entail of instead of removing the entire tumor, the surgeon would remove just enough tumor around the spinal cord to create a small gap or separation between the tumor and the spinal cord. So metal screws and rods may also be inserted to stabilize the unstable spine. And after recovery, a high dose of radiotherapy is used to destroy the remaining tumors. That's why they call it post-separation surgery radiotherapy. Um, and then the advantages would be it relieves pressure on the spinal cord immediately. It preserves neurological function. It stabilizes the spine and allows highly targeted radiotherapy afterwards and better local tumor control than either surgery or radiotherapy alone in suitable patients. So it combines both methods together in one. But then the disadvantages would be major surgeries. The major surgery might come with the risk of infection, bleeding, and anesthetic complications, such as giving overdose of anesthetics. And recovery will take time from the surgery, and it's not really suitable for patients who are too frail already have widespread disease. Could you move on to the next slide, please? Yeah, thank you. Moving on to surgical decision making under pressure. There are various pathways that they can go through, and I'm going to navigate between them. And then the first one would be surgical versus non-surgical decision pathways, where the doctor has to decide whether to admit the patient for surgery or to just focus more on radiotherapy or chemotherapy. So surgery would be considered when the patient is still ambulatory. And what ambulatory means basically is that the patient is still able to walk with or without assistance. So why it would be considered for this patient is because the patient who can still walk before surgery will have a much higher chance of walking afterwards. So um, paralysis is not at a high risk. um and then once paralysis has already been present in the patient otherwise for a long time, surgery is much less likely to restore movement, so they wouldn't consider the patient for surgery if the patient is not ambulatory. And then surgery would also be considered if there is a single level compression. So single level compression basically means the cancer is pressing on only one section of the spinal cord rather than multiple levels. So an example would be the tumor is compressing at only the eighth thoracic bone in the vertebra. Yeah, and then they'd they'd consider them for surgery, and that would be because the single operation would be targeted basically on that particular area, so it would be technically easier and more likely to relieve the pressure more effectively. And then reasonable performance status. Reasonable performance status is a measure of how well a patient can carry out everyday activities. So doctors would often use a scale called the ECOG performance status. And then there's a score from 0 to 4, where 0 is being fully active, 1 mild symptoms but active, 2 able to perform self-care but not able to work, and then 3 is limited self-care, and then 4 is completely bedridden. So patients with ECOG from scale 0 to 2, from numbers 0 to 2, are generally better candidates for the surgery because they're more likely to tolerate the operation and recover more quickly. And then tumor type likely to respond poorly to radiotherapy. Now, some cancers are radioresistant, meaning that they do not shrink well with radiation. Some examples of these are kidney cancer, melanoma, and sarcoma. And if radiation is unlikely to work, then surgery may be a better option. And then moving on to the non-surgical decision pathway, the radiotherapy would be preferred when the candidate is the patient is a poor surgical candidate, whereby the patient may have severe heart or lung disease, are very frail, have poor performance status, and may have a very limited life expectancy. And then they may also radiotherapy may also be preferred when the tumors are radiosensitive, which means like the cancers shrink well with radiation. Sorry, sorry about that. The cancers shrink well with radiation. So the examples may be lymphoma, multiple myeloma, small cell lung cancer, and germ cell tumors. These patients would often improve without surgery. the patients with these tumors would often improve quickly without surgery. And then radiotherapy is also preferred when the metastatic disease is widespread. This means that the malignant cancer, is spread to many parts of the body. So if someone has advanced metastatic disease, the risks of major spinal surgery may outweigh the benefits. So in these cases, radiotherapy and symptom control are often preferred. Moving on to prognostic factors influencing the operability. Um, they would normally a factor would be preoperative neurological status. So preoperative means before surgery, and then neurological status refers to how well the nervous system is functioning. So doctors would assess the muscle strength, walking ability, sensation, reflexes, bladder, and bowel function. This would normally be collated from the multidisciplinary team, such as the physiotherapy and the healthcare assistants, the nurses, and in charge as well. And then patients with better neurological function before surgery generally have better outcomes. Then primary tumor histology. Primary tumor is like the original cancer where it started. So if the cancer in the liver, for example, they call it liver cancer. So histology is the microscopic appearance of the tumor under a microscope. So different tumor types behave differently. Like for example, breast cancer responds well to treatment, while kidney cancer is more resistant to radiotherapy, as I've mentioned before. So knowing the histology would help doctors choose the most effective treatment, and would help them like differentiate whether to do a surgical procedure or focus more on radiotherapy or chemotherapy. Um, Systemic disease burden. Systemic means like the metastasis is affecting the entire body, and then the disease burden refers to how much cancer is present throughout the patient's body. And then um, a lower disease burden would usually mean a better chance of benefiting from surgery. Expected survival. Doctors normally estimate how long the patient is likely to live, and that would move on to like um, breaking hard news, which Silva's going to cover on um onwards later on. Um, if the expected survival is more than 3 to 6 months, surgery may provide meaningful benefit. But if it's only a few weeks, surgery is less likely to improve the quality of life, so palliative treatment would be more appropriate. And then spinal stability, which is for example, it's like the SINS score. SINS is basically spinal instability neoplastic score. It is a scoring system used to like determine where a spine weakened by cancer is what sorry, is a scoring system used to determine whether a spine weakened by cancer is stable or unstable. So the doctor would consider the tumor location, the pain, bone destruction, spinal alignment, vertebral collapse, and then involvement of spinal joints during movement. So the different scores range from 0 to 18. So 0 to 6 means stable, 7 to 12 would be possibly unstable, and then 13 to 18 would be definitely stable and would often require surgical stabilization, which would like they may use what's it called post separation surgery, post separation surgical radiotherapy, um, which they may use in that case. Um, and then moving on to the emergency pathway. This would outline the immediate steps when MSCC is suspected. Um, for immediate high dose steroids, They usually use dexamethasone to be given as soon as MSCC is suspected, such as I've said earlier. And then the purpose would be to reduce the swelling around the spinal cord, relieve pressure, and help preserve nerve function while awaiting definitive treatment, as I've said before. And then urgent MRI. MRI, this would show the exact location of the tumor. It would show how much the spinal cord is compressed and whether multiple spinal levels are affected. The MRI should be performed urgently because early diagnosis normally improves outcomes, and if not done promptly due to waiting times or something like that, it could be fatal in some instances. And then the MDT involvement, which is the multidisciplinary team involvement, where a group of specialists would work together to decide the best treatment plan. And then the typical members of the MDT would be the oncologist, which is the cancer specialist, the neurosurgeon, orthopedic spinal surgeon, the radiologist, which is the imaging specialist, the specialist nurses, and then the physiotherapists. It's important to recognize that each profession in the MDT is as important as each other, as each professional contributes expertise to ensure the patient receives the most appropriate care. And then finally, the decision, which is to decompress and stabilize, or radiotherapy versus um, palliation, which is they're basically um, considering which of these three options would be best for the patient. And then for decompression, they would choose surgery to remove the tumor pressing on the spinal cord to relieve pressure. And then to stabilize would be insert metal rods, screws, or cages to strengthen the spine and prevent vertebral collapse. And then the second option would be radiotherapy, which would be used when surgery is unsuitable or after surgery to destroy remaining tumor cells. And then palliative care or palliation would be treatment focused on relieving symptoms and maintaining the quality of life of the patient when curing the cancer is unfortunately not possible. And it may include pain relief, radiotherapy, physiotherapy, psychological support, and hospice care. Thank you. I'm going to pass on to Silva now. Thank you.
Um, I'm not sure if Silva's here. I don't think she is. So I'll just cover her sections as well. So, in terms of communicating the cancer diagnosis, so it's very important to choose the right communicating strategies because that significantly affects a patient's emotional response and also the resulting treatment outcome and prognosis as well. So a poor doctor-patient communication that can lead to physiological distress, including anxiety, depression, and ill physiological adjustment to cancer. So, a study concluded that a diagnosis should be given face to face in a personal setting rather than on the phone or in an impersonal setting. And physicians should plan to talk for longer than 10 minutes and discuss the diagnosis and treatment options whenever possible. And I did have a statistic, yes. So there was a review of studies on patient preferences as well regarding disclosure of terminal diagnosis. And this was found that 50 to 99% of patients desired full enclosure. So there are, however, communication barriers when it comes to talking to patients about their treatment options and prognosis. And the main ones are cultural differences, paternalistic views, and family dynamics. So there are general tactics of communications that can help you overcome these communication barriers, and they are to avoid jargon and practice active listening. Bad news should also be communicated to a patient in a supportive environment and in a simple but not blunt terms. It's also to remember in this case the duty of candour, which is a legal and ethical obligation for healthcare providers to be open and transparent with patients when things go wrong in their care. And some doctors also use spikes, which is first of all, you set up and start talking about their prognosis. And you also have to think about the patient's perspective as well and ask the patient what they would like to know. Sometimes they would like to know certain parts of they would might want to get straight on to talking about the sort of treatment options that are available to them. So that's why you need to also make sure to provide information in small pieces and also not overwhelm them as well, because hearing about what they've been diagnosed with, their diagnosis can be overwhelming to them. So it's important to also give it in small pieces of information at a time, and also empathize with the patient's emotions whenever you can as well, actively listening to them. And the main thing you also have to make sure is to set out a proper medical plan of action that they also approve of and that they also understand the sort of treatment options and support that are available to them as well. So then we have the importance of consent, capacity, and life-saving surgical decisions. So why is consent difficult in emergency oncology? Well, because you have cases where you have impaired capacity due to patients being in shock, pain, sepsis, or being neurologically compromised. And there's also this issue of there being time pressure, and so you're unable to have these full ideal consented discussions between the patient and the doctor. And the patients may also be acutely distressed, confused, or limited in their understanding. So, practical strategies for surgeons to use when you come across these cases are you would want to use simple language and repeat key points. You may also, with the patient's preferably with the patient's consent, involve the family for support and context as well. You would also want to document what was discussed, even briefly, that's very important. And you would want to clarify whether the intervention you're providing is life-saving, stabilizing, or palliative. And you'd also want to ensure the patient understands the immediate risk of not intervening as well. But ultimately, when you can get the patient's consent, that would be your first call to action. So, Precious, would you like to lead the interactive quiz?
Yeah, no problem. Yeah, okay. Um, just give a thumbs up if you're ready for the quiz. Okay, I'll just go on. In the first question would be, in malignant spinal cord compression, which factor most influences whether surgery is appropriate, even more than tumor histology? The first would be number of metastatic sites, preoperative ambulatory status, patient age, or duration of symptoms. And please explain your answer. Thank you. I've just seen one an answer saying two. Could you please explain why you think two? I'm just gonna give like a few more seconds on this. Okay, I've seen an answer saying one because it shows the intensity of the case, so therefore the urgency. Okay, yeah, that is really important. Any more ideas? I'm gonna let Maria finish typing, then I'm gonna move on. Okay, I've seen Maria say two because if a patient is not ambulatory before surgery, it has even more risks of complications. Nice try. Not nice try. Nice point. And then one helps to triage patients accordingly based on their needs. Okay, so a lot of good answers there. The answer for question one would be two because it gives one of the strongest predictions whether a patient benefits from the surgery, as I spoke about during when I was talking about whether surgical versus non-surgical decision pathways. So the first one was whether the person would be ambulatory, so whether they can walk, and it would let them recover quickly after the surgery. And if they don't have and if they have the preoperative ambulatory status and it shows that they have already had paralysis, the surgery would not be effective at all. So that would be question one. Could we move on? And then let me explain why one, three, and four aren't right. Number one is quite important as I said before. It does show the intensity of the case. So therefore the urgency, but and because it also affects prognosis. However, it would not predict the neurological recovery as strongly as whether the patient can already walk, if that makes sense. And then for patient age, older age alone should never decide surgery. I mean, that's basically ageism. And a fit 80-year-old may do much better than a frail 50-year-old. So definitely not a three. I'm glad no one said three. Four, duration of symptoms is also important. And longer compressions usually means worse outcomes. However, the patient's neurological status, especially ability to walk, is generally the strongest clinical predictor. We move on to two, please. Which of the following situations most clearly invalidates consent in an emergency oncology case? One, the patient is distressed but able to repeat back the risks. Two, the patient is in severe pain and cannot demonstrate understanding. Three, the patient disagrees with the surgeon's recommendation. And four, the patient asks for more time to think. Okay, Ahmed has said two. um, Reduced capacity, so I can't say that consent is given directly from patient. Very, very good point. 2, patient shows signs of reduced capacity. I think this one's a bit easy. Yeah, the correct answer is 2, is mentioned already. I'm gonna have to wrap this up quickly because we're already getting it's already 7 o'clock. Um, for why it's for why valid consent requires capacity. So if the patient is in severe pain and literally cannot demonstrate understanding, they can't really give consent from they can't directly give consent for a particular surgical procedure. So the patient to validate consent, the patient must be able to understand information, retain it, weigh it up, and communicate a decision. Um, if severe pain will prevent understanding, so the capacity most definitely might be temporarily impaired. So making consent would be invalid at that point in time. So, yeah, I think we know why not the others, because the first one is able to repeat back the risks. And yeah, can we move on to the third one? Could we just do the third one as the last one? So is that okay?
Yeah, that's
Yeah,
fine.
yeah, okay. Okay, so 3 would be which communication behavior best aligns with the duty of candour in an emergency involving spinal cord compression. 1, minimizing discussion of prognosis to avoid panic, waiting for full MDT presence before disclosing findings, being honest about the risk of permanent paralysis despite time pressure, or honest disclosure despite time pressure. Okay, I've seen an answer 3 or 4 from Ahmed saying being truthful equals aligning with duty of candour, which is good. So you've identified honesty as a key factor there. I'm quickly going to move on and give the answer for 3. For question 3, the answer is 3. Huh. Being honest about the risk of permanent paralysis despite time pressure. Um, this is because the duty of candour means healthcare professionals must be open, honest, and transparent with patients, as has been already said. Even in an emergency, you have to explain the diagnosis, explain uncertainties, discuss important risk, and answer questions honestly. It's not 4 because it's not as explicit as number 3 about the permanent paralysis as being like the crucial as being the main topic of discussion there. It's just saying honest disclosure, so it's a bit too vague. Reminds me of A-level biology, but yeah. Honest disclosure is basically like honestly telling the patient or the patient's family member what's going to happen in if they have to do a surgery, or if they've made the decision, um if the MDT has already made the decision, if that makes sense. Hope that makes sense. Um yeah. For number 1, it's not correct because it would violate autonomy, because the patient does have the right to have truthful information. So minimizing discussion of prognosis to avoid panic does not align with duty of candour. And 2, waiting for full MDT presence before disclosing findings. It would delay important discussions that could delay treatment and worsen neurological outcomes. So yeah, that's it.